One of the major advantages we have is that we have a walk-in surgery system. So I think that it's very advantageous because patients come in with their children to see the GP quite freely. But also I think that would work for other practices who have open access sessions or perhaps a triage nurse as well. And so patients are identified by the GP, and then we deliberately block off time for the HCA, Katie, my right-hand girl, and she has spaces built into her day which she can use for administration, or she can be available for me to do research. So she has those alongside my own sessions.
Obviously everybody knows that we're very busy and the slots won't always marry up with the time that the GP wants me to be available, but we make it work by sometimes having those slots will make it work. And obviously having quite a good team behind, so that other nurses aren't as involved in research, but they will help me if I run behind in my clinic. So they will see some patients, or will go and apologise to people if I'm running late, or try and help where they can, or come and assist with other patients outside of the study if I needed to see a study patient.
If we identify a patient, I will see the patient, explain the study. My partners might highlight them to me and put them in a side room, and I'll go and talk to them. We'll do the clinical observations at that point, usually, rather than once they're recruited to the study, usually because you'd need to do them anyway for clinical evaluation. And then the patient, if they're agreeable, their family agreeable, would go into Katie, and she would do most of the paperwork, and I would go in and join her. So we work very much as a team, a double act, to minimise the time it takes for the GP to actually sit there and do things. And we do that, as I say, by having protected time for the HCA alongside the doctor. I would frame the discussion about randomisation and the importance of the study by working on pre-existing education, hopefully we've already done with the patient prior to this consultation, and certainly in the beginning of this one, that antibiotics are not always necessary, and there are side effects of them, that we've got increasing resistance, that we want to make sure that they're actually used in an appropriate manner. And patients, ordinarily, their families are quite amenable. As far as consent's concerned, normally I would discuss my own patients during the consultation as I'm doing a clinical evaluation. I'd do my clinical side of things and then talk about the study. If partners identified a potential patient, they'd normally get verbal consent to speak to me, and then ask them to sit in a side room, and I'd pop out between patients to talk about it further and explain the study and take consent prior to them going in to see the HCA to do some of the baseline observations.
I will do any observations that haven't been done, take swabs, assist the GP with doing the blood sample, explain the study diary, make sure that they're happy with the study diary, also explain that they can contact us at any time if they need sort of any help or assistance with filling anything in, where they need to send things back to, making follow-up appointments if needed, and just generally explaining and answering any questions that they have, and then obviously waiting for the GP to then come back in with regards to medication, double checking that everything's okay with regards to all of that alongside the GP.